Welcome to the September 2025 Cure JM Town Hall. This particular town hall is entitled Transforming Care Over the Last 35 Years. We have Dr. Brian Feldman with us from the Hospital for Sick Children in Toronto, in Ontario, in Canada. Dr. Feldman is the head of our medical advisory board, and in his 40 years of practice has been one of the foremost leaders in this disease. And I think what you're going to find over the course of this presentation is great encouragement for our future by looking at where we have come over these last 35 years of JM research and care. And speaking of JM Research and Care, let me let you know about a couple of unique opportunities that you have to participate. It's so vital for families experiencing this diagnosis to help participate. Such a rare disease, we need as many participants as possible. These are the clinical trials that are currently enrolling. CAR-T is enrolling at sites all across North America, as well as CAR-NK and anifrolumab. These are all three vital trials, clinical trials of new treatment options that may someday be available generally for kids facing this diagnosis. Another way that you can participate in this research might even just be as simple as filling out a questionnaire. If you'll follow this QR code currently on the screen, you can find several key studies that are currently underway. Research studies, less of a clinical trial and more of your participation either with samples or in questionnaires or in person with some of the other research opportunities that are out there. This is can be a terrifying diagnosis to face, and we want you to know that you're not alone. We, as Cure JM, are providing a variety of connect groups for families facing this diagnosis. There are connect groups for moms, for dads, for grandparents, for young adults. We have a peer support network for teens facing this disease as well. You can find out about some of these events by following this QR code currently on the screen and looking at our events page. I know that we just had 70 moms registered for this most recent Moms Connect group. These are vital opportunities for you to hear the stories of others and also have an opportunity to tell your story and find some hope for the journey that you're on. Now, a quick word of gratitude to our sponsors here. These corporate sponsors invest a lot in making sure we are able to provide family resources like this vital town hall. Transforming care over the last 35 years. Let's take a glance backwards and a hopeful glance forward as well. Dr. Brian Feldman.
James, thanks so much for inviting me, and thanks all of you for having me. So what I was asked to talk about at the family event was what I've seen change over the last 30 years. But of course, I've been doing this for about 40 years now, and I've been running myositis program in Toronto for about 35 years. But my first real impactful experience with children with dermatomyositis occurred just when I had finished medical school and was starting a pediatric residency. And on my first rotation, which was a surgical rotation, the surgeon had admitted two young teenage girls, both of whom had terrible calcinosis that he was removing. And I thought, that's nuts. This is such a crazy condition. There's so many mysteries about it that need to be solved. And it's nice to say that over the last 40 years, some of those mysteries have been or are getting solved. And we can go over my view about that in the next 20 minutes. Now, this is really told from my personal perspective, and a lot of the things I'm going to be talking about are things that I had a hand in, because that's the best way that I can really express this. There's lots of phenomenal work that I won't talk about that's occurred. This actually is the Hospital for Sick Children as it was when I started training there so many years ago. That building hasn't been torn down yet. It's about to be torn down, but the campus itself now has 3 and other buildings and another one planned, and it's 2 massive city blocks. And that's changed a lot over the last years too. But dermatomyositis has dramatically changed in childhood uh, since the 1940s. Some of the first reports came from the late 1940s and 1950s that this was even a thing in children. Before that, we knew about dermatomyositis in adult patients. And if we look back and read the reports by Norman Clark or Per Cylinder from Sweden, I'm not even sure that what they were talking about back then is what we would call dermatomyositis now. So dermato, of course, I think everybody on this call knows means skin, and myo means muscle, and itis means inflammation or swelling and redness. And some of those children had infections that were causing them to have a rash and muscle weakness. The first report of any treatment for this at all was when Ralph Wedgwood published in the early 1950s. You can see the title there, 26 cases in children with a discussion of endocrine therapy in 13. The endocrine therapy was like the precursor to what we now call prednisone. And that was the first time that this was even tried to be treated other than, just making sure that the children were in bed and had enough to eat. But it was really in the mid-1960s with the paper by Betty Banker and Maurice Victor that we started to get an idea of what we're currently calling dermatomyositis. And this was a paper about how the primary problem in this condition is a problem of the tiny blood vessels, the little tiny blood vessels in the body that run through the muscles in the skin. And that's separated out this condition, dermatomyositis in childhood, from some of those other conditions that had been reported on earlier. And by the early 1980s, so I was still in medical school when this came out, Sue Boyer and Jim Cassidy published a review of their patients treated since the mid-1960s. And I put in a red block there, because this is what things were like when I started in this field, that the best predictor of both good functional recovery and minimal calcinosis is early treatment after the onset of symptoms using high doses of prednisone for an adequate length of time, meaning a long time. You just stay on this. And that's the treatment as it was when I started into learning about dermatomyositis very shortly after that. By the time I was in fellowship and finishing fellowship, it was clear at Toronto that we had enough patients, we were finding enough patients that we should start a separate program for the children with myositis. And because of my interest, I was invited to help start that. And in order to do that and figure out what the best way would be for us to organize our program, treat the children we were looking at, and diagnose and follow them, I turned to three of the big experts in the field. Lauren Pockman, who already was very well known in Chicago for dermatomyositis at that port. Barbara Ansell from England, who was a very senior pediatric rheumatologist at the time and had published on this. And Earl Brewer, originally from Texas and then in Cincinnati, who himself was also very senior and quite experienced in this area. They gave me invaluable advice about how to do this. At that time, we didn't have real ways of following our patients to know whether they were getting better or not, other than just asking them. There were ways that we could, and every clinic did it a little bit different, test how strong they were. But starting in the early 1990s, my group had published about using questionnaires that showed high responsiveness and worked really well. Then, along with folks across North America and Europe, we worked out something called the CMAS. I'm not going to ask for a show of hands, but I imagine many of your children or grandchildren get the CMAS on a regular basis. It's when they have to, bend over and pick up stuff and hold funny positions for a while. And we did something called the manual muscle test, which was a scored system for pressing on the muscles and seeing how strong they were. And that led all the way up into the more recent time where we now have very formal and structured ways of telling whether kids are getting better or not. So much so that these have been adopted and used in clinical trials and allow us to do clinical trials to see whether new treatments are really effective or not. Way back when, Lauren Pochman suggested to me that looking at the tiny blood vessels, which are so important in the damage that's caused by dermatomyositis, that you could do that just by looking at the fingernails. And that's because that's the best place in the body to see these tiny blood vessels without doing a biopsy. And so based on Lauren Pochman's comments, I borrowed and then got funded a special microscope. And we started to look at that in our patients. And then we showed that over time, this was an excellent way to follow the course of the disease and was like a window into what was going on inside the body without necessarily having to do a biopsy every time. That the blood vessel changes we saw in the nails mirrored how active the disease was, and this held true over time. And most recently, when we look at our 20 years of follow-up, or some patients almost 30 years of follow-up, we realize that one of the best ways to predict who's going to get that calcinosis that got me so interested in dermatomyositis in the first place is the ones who have the worst blood vessel changes that we can see on the nail folds. So that's progressed until now. Many places all over the world are using this technique that Lauren suggested to me way back when. When we first looked at myositis autoantibodies, many of you will be familiar with these. We did a paper in the early 1990s, published in the mid 1990s, where we looked at all of our patients to see if they had these autoantibodies. And back then, very few of our patients did, because they hadn't yet been discovered yet. Most of the ones that we now look at were not yet known. And over 30 years, what's happened? Now we have many new autoantibodies, and they seem to tell us what's going to happen to the children, what organs might be involved in their dermatomyositis, what their outcome might be, their prognosis. And eventually we'll be able to use these along with some other information to decide how best to treat individual children with myositis. A huge change that's occurred over the last 35 years. When I started in the field, all of my patients had to have a muscle biopsy, which is painful or require an anesthetic, and something called an electromyogram or an EMG, in which needles are stuck into the muscle. Oh, by the way, all my pictures here are not real pictures. These are all AI-generated images. So needles stuck into the muscle, that's also very painful. But with the onset and understanding of how to use magnetic resonance imaging, or MRI, which I imagine all of your children or grandchildren have had now, when we surveyed around the world, very few people are using these painful techniques anymore, except in special cases. They're very valuable still, but just we try to get away from causing pain to our patients at the beginning when they're being diagnosed. Intravenous immunoglobulin, again, something that many of you will have had some familiarity with, sometimes we just call it IVIG or gamma, was something that wasn't used until when I was just starting to open the clinic. In fact, it was our center in Toronto that published the first series of patients in children. It had been studied at the NIH in adults with myositis around that time. We published the first series. 35 years later, what's changed? Well, we now have a big adult clinical trial that's proven that it works very well and mirrored our results. So much so that it's widely used now all over the world for children with dermatomyositis. And our studies have continued to show, using very fancy statistics, that our results are every bit as good as the clinical trial done in adults with myositis. Again, this is an AI-generated image. I actually think it's a pretty good job, because back in the 1990s, this is what all my patients looked like. They were treated with what Sue Boyer had told us had to be the treatment, high doses for a long time of corticosteroids, of prednisone or methylprednisolone, things like that. And they all suffered from the side effects of it. But because of that, we decided early on in the early 1990s to make a change. And instead of using a lot of corticosteroids, we introduced something that people had been doing in asthma, which was a steroid sparing medicine, a prednisone sparing medicine. So we said, let's use methotrexate. So we had some thought that it would work in this condition. It was working in arthritis. And give it right up front at the very beginning. Not wait for the patient to fail prednisone, give it right up front and use much less prednisone. Suleiman Al-Mayouf, who was one of my fellows, when he went back home, published his experience with it. We collected up about 10 years of data and compared it to children from before that who weren't treated that way and showed that it worked very well and led to far fewer side effects. And that was quite influential all over the world and led to a large study in Europe in which they did a randomized trial and compared that approach to the old approach of using just prednisone or using other medications and showed that prednisone and methotrexate at the beginning led to far fewer side effects and a better outcome. And that's widely practiced all over the world now. Many of your children or grandchildren nowadays will also be treated with something called a Janus kinase inhibitor or a JAK inhibitor. And there's been lots of discussion in Cure-JM about these treatments. One of them is called baricitinib, another is called tofacitinib. There's many different types of these, but these are relatively new. They didn't exist 35 years ago. And when Hannah Kim put together one of the first series of these patients, we were lucky enough that they were able to take one of my patients, who I sent down to Washington for treatment with them at the NIH, who I couldn't find any treatments that had worked for over almost 8 years. And she responded dramatically well and was included in this paper. And now JAK inhibition is again used all over the world and patients are doing extremely well with it. And 2 clinical trials are underway right now to prove that it works so that we can get insurance companies all over the world again to pay for it. There's all kinds of stuff happening now. It's such an exciting field to be in. We now have what seem to be potentially effective biologic agents. So these are no longer the typical pills that we use, but intravenous treatments. Things like anifrolumab and dacuzabart, which have, biologic therapies have changed the face of other conditions we look after, like childhood arthritis, changed them completely so they're unrecognizable. And I think that's going to happen for dermatomyositis too. There's very promising results in several clinical trials planned or underway looking at CAR T cells. So these are potentially even cures for dermatomyositis. And who knows what's next? I got approached by a company just 2 days ago about off-the-shelf CAR T cell therapy that's you don't even need to harvest your own blood cells and go through chemotherapy. You can just use these things and they'll fight dermatomyositis. So we may take part in a trial that looks at that. But I think one of the most important reasons why this has changed so much and we've made so much progress over the last 35 years is the rise of network collaborations, people all over the world who have come together to solve the problems of this very rare disease. My involvement began, probably all of our involvement began with a very, very small group of people who met once a year at the American College of Rheumatology. We called ourselves the Juvenile Myositis Study Group. This is not a picture of us. This doesn't even look like us. The only thing similar to us is the fact that we were that many people sitting around a small table and discussing things that we could do to improve the lives of our patients who had myositis. And many of these folks, some have passed away and passed on now. Many have become senior leaders or are current senior leaders in this field. But that small group in concert with adult groups that are trying to do the same thing, became something called the International Myositis Assessment and Clinical Studies Group, or IMACS, which has had an influence in clinical trials all over the world. And some of the folks there helped work with families to begin in 2003 the Cure JM Foundation, which you guys are all members of, which has contributed so tremendously much to the progress in this condition when I compare it to other rare diseases for which there is no strong family foundation and advocacy group. And now those collaborations have spread. We have CARA in North America, which right from its very beginning, when we started it, we made sure had a myositis committee. PRINTO in Europe, which has studied clinical trials in myositis. The Pediatric Rheumatology European Association, which has a myositis working group and now a whole new research network. The SHARE guidelines that we did in Europe a number of years ago, and we're trying to revise now so we have new guidelines for treatment and diagnosis. Along with the adult treaters, we've developed I shouldn't say we've developed, I just went along for the ride, but the Global Conference on Myositis, the GCOM, I couldn't find a picture of the first one. The second one was done in Potomac. This year is going to be in Lisbon. And so we're moving up and out. And then the IMAS, which is an international myositis society, which is really contributing to things like IMAX and the overall growth in our understanding of how to best take care of your kids. So we've come a long way. In just the 35 years of my career, we've really gone from Stone Age, we had one treatment, to the modern age where now we've got new treatments coming out all the time, much better outcomes for our patients, far fewer side effects, and a much better understanding of what the disease is all about. And most recently, I think that a huge thing in North America, and not just North America, because it also includes England and Italy, is the Cure GM Centers of Excellence in the Clinical Care Network. This is now, and James, you can correct me if it's increased since we talked in the summer, but it's 33 hospitals, 59 specialists, 4 centers of excellence across those 4 countries, where people who have a strong clinical interest in looking after your children can get together, share our experience, share what works well, and make sure that children are treated in the best possible way.